Welcome to Plastic Surgery 90210. My name is Ariel.
And I'm Dr. Katzen.
Today we are talking all about post-operative pain control.
Yeah, that's a big topic.
Yeah, it's like the biggest question we get each
Exactly.
time.
So when we post these videos, usually the most common statement is, ouch, oh, that's gotta hurt. Is the patient awake? Are they in so much pain? So we're gonna talk about pain control.
And today we have amazing matchas and coffee.
Yeah.
Once again, sponsored by Fairgrounds. Thank you, Fairgrounds. We have a couple of Earl Greys here.
Yep.
We have the Rose Cold Foam, and then we also have an Americano. And then out there we also have a Cortado, which is Anna's favorite.
Yeah. These are mine.
Yeah.
Those are yours.
Okay.
All
All right. Cheers.
Good. Cheers. Yummy, yummy.
Yummy, yummy.
And to a great day.
To a great day.
Try to get it just right there.
I love that so much.
Oh, so good. So the majority of the cases that I do are done under general anesthesia. That means you're completely asleep. You do not feel anything during the procedure. And then when you wake up, the pain sort of escalates a little bit, not that much. Under IV sedation or twilight, as we call it, or even local anesthesia, you feel a lot of the procedure. You feel the needle going in, you can feel the procedure. So in those procedures, it's a lot more painful than general anesthesia.
You also do like much more invasive procedures than other doctors because you do a lot of massive skin removal surgeries.
Correct. So you can't do those under local, and you
Uh-huh.
can't do those under twilight anesthesia. So these are bigger procedures. And also when we do liposuction, when you do liposuction under local or tumescent twilight anesthesia where you're kind of awake for it, there's sort of a maximum amount of fat you can remove. With general anesthesia, you can remove more fat because you're not tied down to the amount of lidocaine that you can give in the tissues.
Got it. We were just talking about how one of the most common questions we see on our page all the time is, was there pain? Did this hurt?
Sure.
How painful is this?
Or wow, that's got to get hurt postoperatively.
Yeah.
Well, not so much, not as much as you think. So there are many layers that we use to minimize the pain after the surgery. So pretty much the first thing we do is we use this handy dandy On-Q pain pump. On-Q is the name of the brand, and basically it's a balloon within a balloon. So you've got an exterior balloon here and an interior balloon that's filled with a local anesthetic. I like to use lidocaine, okay? And as the days go on, that balloon squeezes the lidocaine through this tubing, through the tubing, and this part of the tubing is inside your body. It lays typically on the rectus abdominis muscle when we're doing a tummy tuck. If we're doing a thigh lift, it goes down the inner thigh. But this little tube is inside your body, and it sprinkles lidocaine into the tissue. Every couple of minutes, it's sprinkling a little bit more to numb up that area. So this works for maybe about 5 to 7 days, and it's extremely effective. In my opinion, much better, lasts longer, and is stronger than another alternative, which is called Exparel.
Okay, so you prefer the On-Q.
Yeah, so I prefer the On-Q. So whenever we're doing a surgery, we try to incorporate this, whether it's the tummy tuck or the body lift or the thigh lift or the arms or even breast surgery, we like to incorporate this.
So it's like a maintenance pain control type
Correct,
of thing.
correct. So in postoperative period, when you're experiencing pain, pain sort of escalates. All right, so it goes from a little bit to a little bit more, a little bit more, a little bit more. This wipes out at least the baseline of pain. Maybe it wipes out the pain from, if pain is rated from 1 to 10, maybe it wipes out the pain level from 0 to 2, let's say. So it wipes out that baseline so you don't have that pain. Okay, so that's the level 1.
Okay.
Okay.
What is level 2?
Level 2, good. I'm glad you asked. Level 2 is a relatively new medication called Journavx. Okay. And Journavx has been out for maybe about a year now. So it's sort of revolutionary in the way it works. All the other pain medications, Oxy, Percocet, Norco, hydrocodone, all those work centrally on the brain. Okay, so that means you have messages throughout your body, and it's sent to the brain. And those pain blockers, painkillers, block the receptors in the brain. So that's why you can feel a little fuzzy. You can get addicted to the medication. You can get some pretty bad constipation to the medication. But it's a central blocker. So those are all the other painkillers. This painkiller, Journavx, blocks the messages from the periphery ever even getting to your brain. So it's a sodium channel blocker. So when you have pain, say on your finger or your arm, for that message to get to your finger or arm to your brain, it goes through these things called sodium channels, okay? And it blocks those sodium channels so the message doesn't even get to your brain. So it's like the email's not even been sent.
So is that actually less like traumatic for the body?
Absolutely.
Oh,
because
wow.
the messages aren't being sent. So Journavx we try to use pretty much on all patients that we're doing surgery on. And Journavx is a little bit different in that we have you take it every 12 hours. Whether you have pain or not, it just dulls out that level 2 pain, which is maybe that pain level from maybe 2 to 4. Okay, or maybe even 5. So I've had a lot of patients do some major procedures. We're talking like tummy tucks and thigh lifts and posterior buttock lifts and body lifts just with the Journavix and maybe with some breakthrough Tylenol, and that's it. Nice thing about the Journavix too is no addiction spectrum. You can't get addicted to the stuff as far as we know. It doesn't cause that fuzziness in your brain. Doesn't make you feel sort of drugged out, and it doesn't cause constipation. So sort of revolutionary in terms of the treatment of pain.
Okay, so it sounds like we have levels 0 to 2 taken care of by,
Yep.
and out of 10. This is out of 10, you would say?
Yeah, out of 10.
Okay, so 0 to 2 is taking care of on-cue pain pump.
Yep.
2 to 4 to 5 is taking
Yep.
care of the Journavix.
So that's pretty much half your pain.
Yeah,
Okay.
and most times people don't always get to like that
Correct.
8, 9, 10 anyway,
Correct.
right?
So you look at my videos and you may think, oh my gosh, the pain post-operatively, not so much, okay? And then the next level, sort of level 3, we go with things like Percocet, oxycodone, Schedule II narcotics, which again work centrally on the brain, and those take care of the pain. Then there's another medication called Flexeril. Flexeril is a muscle relaxant, and it helps the muscles to relax, and helps you as a patient to relax too. So those are sort of for the upper levels of pain.
Okay, and the like Flexeril, like the muscle relaxers, how come that helps with pain?
Yeah, so remember when we're doing a tummy tuck or a body lift, we're plicating, we're suturing
Oh,
that
and it's all
six-pack
tight.
muscle, and we're tightening that muscle,
Yeah.
and the muscle's really tight. And you may remember during the like the body lifts and the tummy tucks, the patient will be under anesthesia, general anesthesia, but they may not be paralyzed. Okay, so there are different. I'm not an anesthesiologist, but we give medication to sedate the patient, put them to sleep, and then there's another medication which paralyzes all the muscles. So you can be asleep under general anesthesia, not paralyzed, but you're sedated, so we can intubate you. Okay, so you remember when we're doing muscle plication, I ask the anesthesiologist to paralyze the patient.
Right.
So then they give a special medication to make all your muscles go like a jellyfish. So it can really tighten those muscles.
Yeah,
So
and
they
the
go-
muscle gets all boom, boom.
Yeah, exactly, like a jellyfish.
Yeah.
And then I'm able to suture the muscle together, and then the anesthesiologist can either give a reversal agent, usually not, or let that paralytic medication wean off, and then the muscles just, by the end of the case, tighten up.
Okay, so does the Flexeril and muscle relaxer do kind of what the paralyzer does?
Exactly, it
Okay.
relaxes the muscle.
Got it.
And it's really good for the rectus plication, or if people get really anxious after the surgery, the
They tense up?
Exactly.
Uh-huh.
So I tell the patients, try to analyze your pain, okay? If everything hurts everywhere, well, maybe take the Percocet. If you just feel really tight, clamped down, you feel like everything is just constricted, maybe take a Flexeril.
Got it. All right, so you pretty much have pain control taken care of.
Yeah, so in 25 years, I have never had a patient go to the emergency room for pain out of control. With that menu of the on-cue, the new addition of this Journavix medication, which is really revolutionary, it's amazing, and then the additional Percocet and Flexeril on top of that really treats all the pain.
Wow.
Yeah.
You say pain is like, it varies from person to person,
Correct. Pain is subjective, okay?
Okay.
Pain is all up here, all of it, all right? Your pain level and my pain level completely different.
Because we receive it differently in our brains.
Correct.
Even if
And-
we get the same kind of like.
Correct. So they're different. Pain's a very interesting topic, and there are many books written on it. But it has to do with the pure biology, the nature of the injury, your interpretation of that injury in your brain as a biologic, and then also social. Okay, so different cultures interpret pain differently.
Oh,
It's pretty
really?
amazing. Yeah, it's pretty amazing. So I've had some patients do like complete body lifts and thigh lifts, and she only took 3 Tylenols. That's it.
Wow.
That's it. Same surgery, different patient, maybe half her age. That patient was on Schedule II Percocets for maybe about 4 months, taking them every 6 to 8 hours. So it's an interpretation of pain, and then your biologic messages.
That's interesting. And have
Yeah.
you noticed patterns within the different cultures?
Yeah, definitely.
Oh yeah?
Definitely.
Wow.
Yeah.
So let's talk about narcotics versus non-narcotics. So Journavix will be considered a non-narcotic.
Yeah, Journavix is a non-narcotic.
And then the Percocet is
Are
considered
narcotics.
What's the biggest myth you hear about pain after plastic surgery?
So, a lot of people may not have the procedure because they're so scared about the postoperative pain, okay? A lot of patients think, okay, I'm going to be in so much pain, I don't even want the procedure. Or maybe they're, well, I'm going to be in pain, I'm going to have to take narcotics, I don't want to risk getting addicted to the medication. So getting addicted to the medication is pretty rare, okay, sometimes can happen. So it's very important you work with your plastic surgeon to make sure that you don't get addicted. So we prescribe them in small batches, like maybe about 20 or 30 pills at a time, and over that course, we're able to monitor you, making sure you're not taking too much. And then if you need a refill, every time we refill, we're sort of reevaluating the patient, making sure they're not taking too much and making sure they're not getting addicted.
One of the misconceptions I hear all the time is like people saying, well, it's going to feel like your whole body is sawed in half for a body lift, for example.
Yeah.
And it's like the skin maybe, and then the muscle is tightened, right?
Correct.
But it's not like your whole body is being sawed in half.
Correct. So
Yeah.
by the nature of the incision, it looks like you've been cut in half because we're doing a tummy tuck, hip lift, and buttock lift all at one time.
Right.
And the incision goes like that,
Uh-huh.
but we're not cutting you in half. All right. And if you think about if you're going to design the human body, what would you do? And you only have a limited number of things you can put on the body. So you're going to put all your receptors, okay, your things that touch.
Like the pain receptors and
Pain
everything.
receptors, exactly. Things that you feel and touch in interacting with their environment. Things like heat, things like cold, things like vibration, things like pain, you're going to put those on the skin. Why put them on your small intestine? Or why put them on your liver? Because people aren't going to be poking your liver. Your liver is not going to be exposed to things. So all your sensory nerves are, all throughout your skin.
Basically,
so yes.
a paper cut on your skin would hurt a lot more than a paper cut on your liver?
Absolutely. Or a paper
Interesting.
cut on your skin would hurt a lot more than cutting your liver in half.
What?
Because the liver really doesn't have any sensory nerves, okay?
That's interesting. Stomach too?
Stomach too. I just think about if you're designing a thing, a tank,
Yeah.
or whatever you're designing, you're going to have all your receptors on the outside.
Because that's what you have to protect.
Exactly.
Uh-huh.
Why have them on the inside?
Uh-huh.
So, yeah.
Okay.
So when you're thinking about surgery, your pain is going to be interpreted from the trauma to the skin and just underneath the skin, not really the muscle tightening. Not the muscle's going to feel tight, but it shouldn't be painful.
Okay.
Okay. So when you're talking about sawing in half, it's just the skin and the nerve endings on the top of the skin that we're dealing with.
Oh, okay. And so when people are getting like bariatric procedures, that means that their pain is mostly incisional?
Correct. The cutting of the stomach really doesn't hurt because it doesn't have any pain receptors. What you're feeling is after the surgery is the pain from the incisions through the skin, not on the stomach.
We should do a fun fact video on that later. That is so
Yeah.
interesting.
Yeah.
Okay, let's talk about like how anxiety kind of plays a factor in a lot of this pain that people feel.
Absolutely,
Yeah.
absolutely. So after the surgery, you're going to feel pain, you're going to be anxious, and we need to sort of try to separate the two. So if you're anxious and you're taking pain medications, it's really not going to treat the anxiety. Likewise, too, if you're in pain and you're taking anxiolytics, that's really not going to work either. So patients in their postoperative period really need to focus on their body and try to separate the two. So in the office, we get patients who are in pain, so we typically take them with Journavx, okay? Or typically we would treat them with Percocet, all right? That's for the pain. But if they're anxious, that's a different type of condition. So for those patients, we may need relaxation techniques, breathing techniques, maybe even some anxiolytics too.
You also do a good job, you and like the nurses as well, do a good job of talking the patients through what they can expect right after surgery, right when they wake up from surgery.
Yeah.
And you guys do this right before they go in. So you guys remind them, take deep breaths. You might be shivering a bit. That's completely normal.
Yeah.
And I think that helps them calm down a lot because when they
Absolutely.
wake up, that's the last thing they remember, right?
Absolutely. So, you can look at my videos. We have a lot of videos of patients waking up out after anesthesia. It's not the violent bucking and jumping around
Yeah.
and like you see on the Hollywood movies. Our wake-ups from general anesthesia are basically just like a smooth landing, like your airplane just kind of landing at the airport. All right. So patients typically wake up from their deep sleep from general anesthesia, and typically they'll be shivering a little bit. Okay, the shivering is usually due to some of the medications we give you. Again, remember we gave you medications to paralyze you, all the muscles go limp like a jellyfish, and then at the end of the surgery, we give you medications called reversal agents to wake you up. Okay, so if you're limp like a jellyfish and I give you medications to contract all your muscles, what do you think will happen to your muscles?
Oh, like.
They'll start to shake.
Yeah.
Okay, so some of the shaking that you feel is due to that medication we give you, which forces those muscles to twitch. So that's why you're shaking a little bit. Also, too, patients may get a little cold during the surgery. That's why we keep the operating room pretty hot and warm, because everything's open and exposed, and you lose a lot of body heat. That's why we have the air warmers and the blankets underneath the patient to keep them warm during the surgery. Okay, so you'll be shivering a little bit. You may, though it's really rare, have a little nausea. We put the nausea patch on before the surgery, so the nausea patch is working during the surgery, so by the time you wake up after the anesthesia, the nausea patch should be kicking in and you should have minimal to no nausea. Okay. Now, things will feel tight because of the procedure we're doing. Maybe it's a body lift or a tummy tuck or liposuction, and you have a garment on top. So when we're doing a body lift or a tummy tuck, we suture the six-pack muscle together. Okay, it forces the diaphragm, the breathing muscle, up. You got a binder, you got a garment on, forcing it up even higher. So sometimes it may take a little bit more effort to take that good deep breath to drive that diaphragm down. So we counsel patients, after the surgery, when you wake up, you're going to be focusing on taking a good deep breath, because the number one thing the body reacts to is air and oxygen. Okay, so that's the most important thing. So when your brain is like, we're not able to take a good deep breath, red alert, so patients get really anxious. So we calm them down and we say, no, work on taking a good deep breath so they can take a deep breath like that, get their oxygen in, brain's like, oh, everything's okay, relax.
And everyone always wakes up fine after the procedure. And yeah, they really are not in a lot of pain right when they wake up.
So and again, it's the residual from the general anesthesia, the local that we put in, the on-cue pain pump kicking in, and the adrenatics. Adrenatics, again, we give the patients 2 pills right before surgery now. So by the end of the surgery, it's already kicking in too.
That's awesome. Personally, I would never choose anything but general anesthesia for any procedure. Because I don't want to be awake for any of it.
So me too. The more you know, the more you know. So a lot of patients are very scared of general anesthesia, and the most common anxiety people present that I see in my plastic surgery office is anxiety towards general anesthesia. I think
fear of not waking up.
Exactly. That's the number one
thing. It's
thing.
the Hollywood. It's the movies.
Exactly. It's the movies. In clinical practice, never seen it happen. 25 years private practice, 10 years of training, gunshot wounds, stabbings, car accidents, everyone wakes up after anesthesia. In the early days, I think 40s, 50s, when we were using ether. Ether's a gas, you put the gas on. Those are very primitive times in anesthesia. Those cases, sometimes we didn't have all the monitors that we do now. In those cases, again, we're talking almost 100 years ago. Sometimes those patients would not wake up, but those are in ether anesthesia. We don't use ether anymore. So you've been around a long time. You've seen a lot of surgeries, a lot of patients. So what have you noticed in patients and their control of pain or their pain experience?
So I think day 1 of surgery, their pain is handled completely. I think day 2 and 3 they start to feel a little more pain, and that's probably the peak of what we see. And then after that, they seem to be pretty fine. I guess if anything, it's their commute to the office because they're finally taking those first steps and stuff. But in general, I also think that when talking to these patients 3 months out, they don't remember the pain. So I'm like, whoa, I remember you being in a little bit of pain, but they're like, no, I don't think it was that bad. And I was like, okay, we're just going to go with that,
That's very true.
Why does that happen?
So clinically, what we see is when the patients wake up, there's still residual anesthesia from the general anesthesia. So that's in their system, okay? And then usually by the 3rd day, that's usually the period of most swelling, okay? So you have initially the holdover from general anesthesia, pain medication is still in their system. And then as they wake up and become a little bit more active, it hurts a little bit more. And then the 3rd day, they're most swollen, so that may be sort of the peak in some of their pressure, because the peak in sort of their pain, because of all that pressure and the swelling throughout everything. Okay, so usually about 3rd or 4th day is sort of their peak of pain. And then after that peak goes down, then they have to get a little bit more mobile to come to the office to see us to make sure everything is doing okay. We take off the garment and everything like that. So their pain sort of comes in little waves, but overall it goes down. But yeah, your brain, I don't think it's programmed or engineered or whatever to remember pain. Okay, so I'm sure you've had painful incidents. Your brain really doesn't like to remember that because it hurts. Okay, so it hurts at the moment. Your whatever that's being injured tells your brain, help, something's wrong down here. Your brain helps that area, and then it goes away. And your brain really doesn't want to remember that anymore. So that's the way I think of it. Sort of like pregnancy.
Right. Okay? Everyone always has amazing. They say that's the best day of their life, and I'm like, whoa, it must have hurt.
and specifically labor. It hurts a lot. We've got epidurals, things like that, but it hurts a lot. And the mother usually doesn't remember the pain, and there are many good reasons for that. But I think the brain isn't engineered to sort of remember pain. It experiences pain, so if you have continuing pain, it'll keep getting those receptors and those messages, but it doesn't sort of, I remember how bad my paper cut hurt, or I remember how bad my ankle hurt when I sprained it.
I remember that one. That was recent. Okay, and then last question. I do notice though that people, if anything more than the incisional pain, they do complain about like their drains. They don't like the pain around their drains, and then once they get those out, they're happy campers.
Correct. Again, remember the receptors, the pain receptors are on the skin.
Uh-huh.
Okay, they're not on the deeper tissues,
Mm.
and the drains have to come out through the skin.
Right.
So every time that drain wiggles, it can hurt.
Oh yeah. That makes sense.
And what do we use to keep the drains from falling out?
Sutures.
Sutures.
Uh-huh.
So again, I'm stitching the skin. Those stitches do hurt, and they're tugging on the drain. Also, I put the drains in a pubic region for the tummy tucks and the body lifts. That's a very sensitive area. So again, you're dealing with sensitive skin, sensitivity to the drain, sensitivity to the sutures in a sensitive area.
Mhm.
All those add up to ouchie drains.
Yeah. So not that drains are bad, but that
No.
is usually the number one thing that people complain about. Even over the body lift scar or
Yeah,
incision. So
true.
that's pretty crazy to me.
Yeah, so again, remember, it's not the pain on the inside that you feel, it's the pain on the outside, on the skin. So that makes sense why the drains would hurt as opposed to the internal stitches for the body lift.
Hmm. And then do you also notice that like the second the drains come out, they're fine?
Yep, they're fine.
Yeah.
It was the irritation.
Yeah.
Okay,
Yeah.
the drain's moving, the drain's wiggling, that hurts.
Hmm. So if you're considering getting one of these procedures but you're afraid of the pain, you could give us a DM, give us a comment, give us a call. We can talk you through it. Everyone ends up okay, and
Yeah.
surprisingly, everyone says they would do it again if they had to.
Yep, absolutely.
Which I'm always like, wow, that's amazing.
And again, it's a trade-off.
It is a trade-off.
You're coming in with excess skin, excess fat. We're getting rid of the excess skin. We're getting rid of the excess fat. You have to experience a little bit of pain, okay? But how you treat that pain and interpret the pain, that's up to you.
Mhm.
And then we get rid of the skin and/or fat, and then we give you a little scar or a bigger scar depending on the
Right.
area.
And that pain is actually so temporary
Yeah.
compared to like how long you're going to benefit from this. One more thing that I did notice is people with positive attitudes seem to
Yeah.
do so much better.
Absolutely.
Yeah.
Absolutely.
It makes a huge difference.
Yeah, and that's life in general, right?
Life in general, yeah. Mhm.
Be
But
more positive.
be more positive, but it seriously affects them physically.
Absolutely.
It's insane.
100%.
Yeah.
100%.
Yeah.
Yeah. I
And
mean,
it's
you
a
can.
pleasant time.
I mean, you can think yourself sick.
Oh,
Yeah.
that makes sense.
Yeah. So think positive.
Yeah.
Yeah.
Alrighty. Well, on that note, give us a call if you're considering plastic surgery, 310-859-7770, or DM us on Instagram.
Yep, give us a call and we can set up a consultation, whether it's virtual, wherever you are in the world, or physical. You can come on in, but the traffic is getting worse.
The traffic is, and school just started back up, so.
Already?
Yeah, already.
Mid-August,
Yeah.
yeah.
Alright, well, we'll see you next time, and thank
Okay.
you, Fairgrounds.
Thank you, Fairgrounds. Cheers.
Cheers.
Cheers. Cheers.
Bye.
Bye.